fusion technology and kind of what PET-CT is. Um, and then the very end, I've got a little video about what they do to simulate, uh, or it's called a radiation simulation. And that is what you do prior to having any radiation therapy done. And it kind of sets up the landmarks and all of the planning, but we'll go over that in a moment. So, like I said, today we're looking at nuclear medicine, PET imaging, and radiation oncology or radiation therapy. Now, with nuclear medicine, something that you're going to hear a lot of throughout this is what we call radionuclides or tracers. And these are different radioactive materials that we use and we inject into the patient. Um, well, it enters into the patient some way. So typically it's injected, but it can be inhaled and also taken orally. And then what it does is depending on the tracer that you're using is going to attach itself to a certain molecule. And then depending on what specifically you're looking at, that molecule is typically associated with being able to go to that area and more or less what we call hot lighted up or a hot spot. That's the area where the most radiation is concentrated. So that's kind of how we see what we're looking at. Um, the patient ultimately becomes the radioactive source. Depending on some of the different therapies, there are restrictions on, like holding young children or, making sure that you double flush when you use the restroom or, you know, when I worked one of the facilities that I worked at, we actually had a separate bathroom just for our nuclear medicine patients. A few different cameras that we'll go over. And then one thing that you might hear about is SPECT imaging. So SPECT is just single photon emission computed tomography. So what it does is it actually picks up a 3D image of that nuclear study. So typically you'll have a dual head system like this. It will rotate around the patient, picking up the radiation that they're putting off, and that's going to create a 3D image. Now, the nuclear medicine scans and the SPECT scans are not going to be high definition. What we're looking at is function more than anatomy. Now, there is something called fusion technology where we take the CT and a SPECT image and we fuse them together. They're typically going to be done or they're going to be done on one single camera system. So the patient's going to lie down. It may do the CT first and then take the readings for the nuclear study or the SPECT imaging. And that is going to give you the image, that we're looking for. So here is an image of a nuclear study. This is a Meckel's diverticulum study. So some patients, typically seen in pediatric patients, the tract of the blood flow that came in through your belly button and connected into your abdomen actually forms this diverticulum. Uh, so it is a GI study that we look at in nuclear medicine. But we can do bone studies, so pretty much anything within the skeletal system, anatomic and functional studies of the kidneys, brain scans to evaluate for stroke, Alzheimer's disease, Parkinson's disease were all originally done on nuclear medicine. Now we are seeing a giant shift away from nuclear medicine and towards MRI and even CT and ultrasound are able to give us imaging that's going to greatly reduce the amount of radiation. The other thing is nuclear medicine is extremely expensive compared to some of the other modalities, especially if the patient doesn't show up. Reason for that is those radionuclides are going to be extremely expensive, and if a patient doesn't show up, they will degrade to the point where you can't use them for anyone. So if a patient no shows, you can't bill the patient, but also you're going to have this radioactive isotope that really you can't do anything with. Like I said, there's gastrointestinal studies. So after COVID, we saw a lot of people, or even with some of the newer uh, weight loss drugs, where they're having difficulty or they're feeling full for too long. So we'll do a lot of gastric emptying studies, hepatobiliary studies, liver, spleen. Um, Nuclear medicine's also heavily done in the cardiology world. So uh, if you've ever heard of a stress or a rest test, myocardial perfusion exam, those are all going to be done for looking at the heart and the vessels. And then, like I said, you do have the ability to do different ventilation and perfusion studies that are going to look at the lungs. Now, a lot of times when we think of a nuclear medicine scan, we're thinking about a big unit like this. However, depending on what we're looking at, there may be a special machine that will pick up the radiation. One of the most common ones is the thyroid uptake study, where it uses this little device here. The patient's going to put their thyroid at a certain distance, and then the computer's just going to run and it's going to pick up the amount of radiation that's coming off of the patient's thyroid. This will let them know if the patient is normal or hyper or hypothyroid. Also, if you're doing any type of medication destroying thyroid treatments, so a lot of times you'll give the patient a certain drug that will have a high amount of radiation. It will go there and it will ultimately, pretty much burn out and kill your thyroid. That is typically done in the nuclear medicine department as well. Now, there are some key people in this, and there's going to be a question on the test. It is who gives or who administers the radionuclide or who does the radiation therapy treatment. It is the technologist. Um, the nuclear medicine physician or radiologist, or they're just simply going to interpret the studies. Now, some other important people in the nuclear medicine team are going to be your radiation safety officer. So that's your RSO. And they're going to review the imaging protocols. They're going to go through the dosimetry records. So if you guys have dosimetry badges, there is a radiation safety officer that reviews those. They're going to make sure that you stay below ALARA level 1. If you do hit that, they might have a conversation with you, try to figure out why you hit over a certain level. And then a lot of times we don't see this, but if you hit a Lara level 2, that could mean that you were exposed with a ton of radiation, might have to take a step back out of radiology and work in a different area uh, moving forward. And then there's the health physicist. They are going to do calibrations and maintenance on the equipment. Some basic terminology that you should be aware of is going to be half-life. So when we're talking about radiation, half-life is the amount of time it takes for a radioactive isotope to degrade by 50%. So if the half-life of the radioactive nuclide is an hour, in 1 hour, it's only going to be 50% as strong. In 2 hours, it's going to be 25% as strong. 3 hours, it's going to be 12.2 or 12.5% strong, right? So it just keeps getting half and half and half and half. Um, Cyclotron is a device that some hospitals have that are going to allow you to create your own radionuclides. Decay is the radiation that is coming off of a radionuclide. Uh, and then isotope, cyclotron, Tech 99, those are just other terms you really don't need to worry about. So PET imaging. So PET stands for positron emission tomography. Same concept. We're giving a radionuclide to the patient. And the device is going to create a three-dimensional tomographic image that's going to demonstrate the chemical functioning of the body organs and tissues. So we're looking for uh, abnormal function. A lot of times we'll do it to detect diseases in early stages and then also to measure responses to treatment. So if a patient has cancer, goes through therapy, a lot of time they're going to come back for follow-up PET scans that are going to do, pretty much a whole body scan to look and see if it's returned. Now with PET, it's pretty interesting. So what happens is that radionuclide is going to be administered into the patient. It is going to be an injection. What happens then is that nuclide is going to go into your body and go to certain areas. Uh, what happens then is there's going to be a positron that's going to be emitted from the nucleus when it combines with an electron, and it undergoes something called annihilation. And during annihilation, there are two equal photons that are going to be emitted at 180 degrees away from each other. So these gamma rays are going to pick up this radiation as it's coming off of the patient. And depending on how long it takes for it to get from, to hit the two different areas, is going to tell the camera where that data point originated. So, uh, you know, super smart people figured this out. I have no idea how how half of the things that we utilize, actually came about, but absolutely incredible. Now, common uh, positron emitting elements are going to be oxygen, nitrogen, carbon, and fluorine. And the radionuclide compounds that we typically look at are FDG, O15, N13, and C11. And each of them are going to kind of be for something specific. So FDG is looking at glucose metabolism. Uh, O15 is going to be for blood flow and perfusion studies. Again, N13, same thing, blood flow and perfusion. And then C11 is going to be for amino acid metabolism. Now, like I made mention before, the cyclotron or cyclotron, depending on how you want to pronounce it, is going to be for some of those busier nuclear medicine departments, where what it does is you're going to buy more or less a kit. The kit goes in there, and then it's going to accelerate subatomic particles, and those directed particles are going to go to non-radioactive targets, which ultimately produce a radionuclide. Now, the good thing about this is, the kits are relatively inexpensive. You're able to make a bunch of it. You can do with it what you will. However, the tracers do have a very short half-life. Some of the half-life is as much as 2 minutes long. Other half-lives are up to, 110 minutes. So it is very important that when a patient is scheduled, that they're coming in at their specific time, right? So if you wanted to give a patient a uh, a radionuclide that has a half-life of 120 seconds, you got to figure out when that tracer is coming out of the cyclotron, and then at what strength you need it to be when the patient's exam is. So there's a lot of calculation, a lot of figuring out. Um, Really, really interesting. Unfortunately, I think nuclear medicine gets a pretty bad rap that you're just sitting there. Um, I will say there's a level of, some of the different tests take 2 hours long. Some of the gastric emptying can take 3 hours long. Um, However, there's so much more that goes into it that a lot of even the general public just have no idea. Now, clinical applications, obviously, biggest one out there is going to be the oncology aspect of it, right? So we're going to assess stage possible tumors. This is when we're using that FDG, which is a glucose metabolite. And what it does is anywhere there is a tumor, tumors love sugar. So the FDG is going to be absorbed by that tumor and it's going to collect there. Now, there are two areas on a patient's body, even if you're totally healthy, that when you get FDG, it's going to go there. It's going to go to your brain because your brain loves sugar. And then it's also going to fill up into your bladder. Reason for that is as it's processing through your body, it will break down into the waste, and the waste ultimately will go to your bladder. So if you ever have a PET scan done and you see a hot spot in your brain and a hot spot in your bladder or in your pelvis, nothing to be worried about, though it's completely normal. Now, like I said before, cardiology is going to utilize nuclear medicine and PET imaging probably more than most other specialties out there. And they're utilizing it to look at the heart, coronary artery disease. So this image here, this is showing a patient that has uh, they're evaluating the heart perfusion, so looking to see if there's an adequate amount of blood flow to the heart tissue. You can see this area here does not have blood flow. So they might go in, do some surgery, do some type of treatment, and then they're doing the glucose metabolism afterwards, and you can see that that now has normal blood flow following treatment. Again, early days prior to MRI, we're doing uh, a lot of imaging with nuclear medicine and PET for the brain. So looking at epilepsy, this is still done. This is probably the exam that my techs get exposed to the most amount of radiation because what they're doing is like what we do is we'll bring in a pediatric patient, we'll take them off of their anti-seizure medication. We'll do this in correlation with neurology. Neurology will hook them up to a bunch of electrodes, and then pretty much my nuclear medicine tech will sit there waiting for the neurologist to tell us that the patient's having an active seizure. Soon as they're having an active seizure, we're going to inject that radionuclide, and then we're going to take the patient down to get scanned. So if we inject the radionuclide during the seizure, it's going to light up the specific area where that patient's seizure is originally originating from. And depending on where it's at, they may be able to do surgery to remove that section, and ultimately, cure the patient from having seizures. I can tell you that I have scanned so many normal looking people out there that you would have no idea had anything wrong with them that do not have a left temporal lobe or a right temporal lobe. Uh, you know, so just because there are disorders out there and things like, chronic seizures and things like that do not mean that you can't get them fixed. Now, sometimes you can't, but by doing these studies, we're able to help the physicians figure out what we can do and what we can't do. Brain mapping for neurology is huge as well. So we'll do brain mapping to specifically locate uh, different function of different areas of the brains that has different functions. So we can specifically look at the language area, the memory area, the vision area, the movement area. And by fusing the images with a, say, CT scan, we're able to see where they fall in relation to a tumor, or this example right here is an AVM, so an arterial venous malformation. So they're going to want to go in, and they know that these areas with the blue arrows are demonstrating the areas of the language region of the brain. So they're going to know we need to avoid those specific areas if we go in to fix this AVM. Any type of CNS tumor imaging, the C11 and FDG are going to help uh, specifically look at the areas of the brain. So even though the brain will highlight, you're able to still image the brain and see specific areas. Again, when you're looking at it and it's going to be a histogram type image where you're able to window level to be able to see exactly what's going on. Early days, we were doing a lot of scans for dementia in PET imaging. So column A right here is a normal brain, and as we move from from left to right, you're going to see the bright reds, the yellows are going to disappear from mild dementia to severe dementia. Now, PET-CT fusion technology. So these are probably going to be probably the second most expensive machine in the hospital, only to maybe MRI. I mean, we just did a big renovation, added a new PET scan for right around 3.6 million. So our new PET um, or with PET imaging and fusion technology, you're doing a PET scan as well as a CT scan. The two data sets are going to be ultimately merged into a single image, and you're going to get a much more high def image than what we saw with the nuclear imaging and CT. So this right here is not a great example, but the next few are going to be really good. So you can kind of see we've got an axial CT image here. We got the PET image here. It's going to overlay, and you get a clear delineation of that medullary thyroid cancer. Now this right here, this is more what we typically look at. So we've got our CT scan here, top of the head to mid top part of the femur. Nuclear study, same thing over here. And then when we merge them together, you get a clear uh, representation of exactly where the cancer is. And you're going to be able to page through these, reformat them uh, using MPR, so multiplanar reformations to get, pretty much any type of image that you really need to. Now, radiation oncology or radiation therapy. So this image right here is a linear accelerator. What it does is it emits X-rays or a beam of electrons to specifically hit an area in the patient's body and radiate it. Now, the formal definition of radiation therapy is going to be the field of medicine in which radiation computers and a team of healthcare professionals treat cancer. There are two different types of therapy. Now, most people think of external beam therapy. So that's, the gamma knife, that linear accelerator, and that's where you're using that beam of invisible radiation to a specific area and, ultimately trying to kill and destroy those bad cells. The other thing is brachytherapy. So if you've ever talked to an older guy that says that he, just had a uh, surgery on his prostate to shrink it, that is brachytherapy. So that is where we're using and inserting low intensity radioactive nuclides into the body, and it can either be in the body or on the body. Really, you just need to get close proximity to that tumor and the cancerous cells. Now, these are typically, we refer to them as radioactive seeds. So they're sealed radioactive isotopes that are placed inside the tissue, into the body cavity, or on the body surface. A lot of times, like I said, we're doing these in the prostate, superficial cancers, localized primary cancer tumors. I think early on they were using it for some different types of skin cancer. Ultimately, it's just easier just to cut those out. And then with the external beam therapy, crazy enough, the first units of radiation therapy were just X-ray units. You might crank up the KVP and the MAS and you try to hit an area. Obviously, those are not going to be as accurate, going to get a much greater amount of scatter radiation. And as times progressed, we moved on to the Cobalt 60 units. Now, Cobalt 60 units, they use gamma radiation. And then as we learned more and we've gotten more advanced, we've got our linear accelerators. And these are going to be those high energy X-rays and low energy electron beam that are treating deep tumors. Now, I made mention of the radiation oncology simulation. So I've only ever seen it in CT. I know our text says that it can be done in fluoroscopy and MRI. I've never witnessed that. I've only ever seen it in CT. Typically, you've got a dedicated CT room that is going to be, quote unquote, loaned out to the radiation therapists for an afternoon, maybe one day a week. And the same type of localization, all the different lasers, everything that lines up is going to be in that CT room as well as in the radiation therapy room. And what they do is they're going to line you up, they're going to mark you. They may create some different immobilization devices that are going to follow you along throughout your treatment. And the main reason for that is they want to localize the tumor. They're going to plan the therapy based off of the images that they have there, pretty much, what they want to try to avoid. Um, I'm sure it's a lot more advanced now. I sat with a dosimetrist back in 2008 when I was thinking about going into that. And literally, you could show where the beam was entering, how much radiation was exposing the other tissues. And then if you change some parameters, you'd see what it changed on the image, and you would just try to position it. That would be done by a dosimetrist, sent over to the radiation oncologist. They would sign off on it, and then you would do your treatment. But like I said, we've got a little video. And then again, the radiation therapist is the one that administers the treatment. The radiation oncologist is who prescribes the treatment. Then the medical physicist and the dosimetrist is going to be the one that creates that desired plan of treatment to figure out what type of dose to the area needs to be there. And then one of the individuals that kind of is the the most overlooked, but one of the most important, is the radiation oncology nurse. And imagine most of the patients that are coming in there are older or they've got cancer, so they're very ill. So the nurse is going to be there to support the patient's care throughout it, make sure that they're okay. Um, it's one of those things that you don't really want to fall on you as the radiation therapist. So the nurse is there to help. And then I just have this little video. It's about 5 minutes long. This is just going through, as you can see, like this stack right here. These are those external lasers. So if you ever are in CT, you'll see CT uses the lasers in the bore. If you've got a room that has these external laser lights, that is because they are doing the simulations in that room. A lot of times there's going to be a different table that actually locks on top of the CT table that's going to mimic the table that they have in there. And then you'll see directly behind this woman here, I believe this is a warmer. And that warmer is going to warm up any of the different types of immobilization devices that they use for the face and neck. But let's watch the video, and if you guys have any questions after, we can talk about it.
Hi, my name is Ashlyn Everett. I'm one of the radiation oncologists at Alliance Cancer Care. Today, I want to tell you what to expect when you come in for your simulation appointment. So if your doctor has recommended you have radiation treatment, the next step is to be given an appointment for a simulation. What is a simulation? When we are going to plan radiation therapy, we need to simulate how you're going to be positioned for the radiation treatment. The goal of positioning you for radiation treatment is twofold. First, we want to put you in the same position each day so that we know we're treating the right area, your tumor. Second, we want to make sure that each day when you're in the treatment position, you're not moving, again, to make sure that our treatment is accurate and we're treating the area that we need to treat. Your doctor is going to order specific instructions for you, particular to your situation. So this is very general guidelines about what to expect for simulation. But some patients find that they're going to be recommended certain preparation instructions when they come in for their simulation appointment. There are some patients who may receive an IV, or some patients may be given specific instructions to drink water prior to their simulation appointment. On the day that you arrive for your simulation appointment, you're going to maybe be asked to change into a gown. I would recommend you to wear comfortable clothing, something that's easy to change in and out of, and you are allowed to keep your shoes on as well. So we're going to talk a little bit about the devices that we use to position you for radiation treatment. Again, this depends on your particular situation. So for patients having treatment in their brain or their head and neck region, we will probably make a mask for you. Yours may not look exactly like this, but it'll be something like this. So when the mask is warm, it actually will stretch down over your face and shoulders to hold you in the same position each day for treatment. This cools down, and then we take a CAT scan of you in this position. For patients receiving treatment to their chest area or even potentially your spine, we may be giving you a bag. It's like a bean bag that actually molds around your shoulders to hold you in the same position. So you can see that it's currently moldable. They will actually turn on a pump, so you'll hear that sound in a moment, that sucks the air out of this bag to help hold the right position around your arms. So you can see that this is now molded around her arms and is actually firm and will hold her in the same position for treatment each day. So in patients that are having their abdomen or their pelvis or their lower spine treated, we will want your arms to be up over your chest so that they're not in the radiation field, and you'll hold on to a ring over your chest, and then we'll actually have a sponge under your legs to hold your knees, as well as a ring around your feet to hold your feet still. So you will see the lasers overlay the X marks covered with waterproof stickers to ensure that she's in the same position for treatment each day. Once the marks are placed, you will then receive a CAT scan. It will be moved into the machine, and the CAT scan is very quick. You move out of the machine relatively quickly, and you can see on both sides of the machine. So this is not one that people typically have problems with claustrophobia. Once your CAT scan is finished, you'll be allowed to get up and change back into your clothes. The staff will give you an appointment for your next visit, which is approximately 7 to 10 days after your scan is completed. This gives your doctor time to plan and customize your radiation treatment to your tumor and your body. You should expect the entire simulation visit to last anywhere from 30 to 60 minutes, depending on your specific parameters.
Hey guys. Well, I hope you found that interesting. Any questions on nuclear medicine, PET, or radiation therapy? Okay, so if we don't have any other questions, I will stop the recording.
Recording stopped.
Because it's such a wonderful weather out here, let's make the code word snowing. Because that's what it's doing outside my window right now.